I think I'm going to start. So some of you know me, but for those of you who don't, I'm Dr. Jane Dematte, and I work with the Northwestern Scleroderma program. And I'm also the director of our Interstitial Lung Disease program here at Scleroderma. And today we're going to talk about how scleroderma affects the lungs. We're primarily going to talk about interstitial lung disease. That's the primary means by which the lungs are involved in scleroderma. But we'll also touch on aspiration lung injury, why that happens, and what the implications are. We won't talk about pulmonary vascular disease. If you wanted to listen to that, you should go next door to listen to my colleague Mike Puttica. So obviously pulmonary vascular disease is another primary means by which the lungs are involved in scleroderma, which will result in pulmonary arterial hypertension. And then the lungs can also be secondarily involved by the pulmonary venous hypertension, which is really due to scleroderma's involvement in the heart that can result in a flooding of the lung with fluids, which we call pulmonary edema. So lots of ways people with scleroderma become short of breath due to lung disease. So what actually is interstitial lung disease? So, the interstitium is sort of the scaffolding of all those little air sacs. So your tracheobronchial tree will branch into smaller and smaller airways and then eventually terminate these little air sacs, which are the functional units of the lungs, and that's where carbon dioxide and oxygen get exchanged with the blood. The interstitium is normally a very fine sort of small space. It houses really just the little capillaries which carry the red blood cells to exchange gas with the air sac. So it's really not visible normally. They sort of demonstrate as these little white lines. So what happens in interstitial lung disease is this area, a bunch of inflammatory cells invades this area and lay down inflammatory milieu and then invite in a bunch of cells called fibroblasts, which can lay down scar tissue. So it's inflammation that will result in scarring of the lung. And here you see it here. So it's this laying down or so invasion with inflammatory cells and inflammatory debris and then scar tissue. And what that does is it impairs the gas exchange that should be happening between the air sac and the capillary, and it also makes the lung volume shrink. So that's what interstitial lung disease is. What it looks like under the microscope, if you were to do a lung biopsy, here would be a normal interstitium, these fine lines with the air sacs interspaced. And this is where you can see there's been a bunch of cells are coming in there, and there's some deposition of scar tissue. That sort of is what this area is here. And radiographically, when we see that on your CAT scan, you've seen pictures of your own CAT scans, you see these thickening lines, and you see some of what we call ground glass. These areas here would correspond to those areas there. So a lot of different ways we can sort of get an idea of what's going on. So how common is interstitial lung disease in scleroderma? So, reported prevalences are anywhere from 25 to 85%, and that's because it really depends on how you find cases. So in a center like ours where we screen for interstitial lung disease using either pulmonary function tests or CT scans, we find lung involvement in about 85% of our folks. Whereas if you wait until the onset of clinical symptoms, and about a quarter of patients with scleroderma will actually have symptomatic interstitial lung disease. So it's quite common, especially the subclinical interstitial lung disease. It doesn't matter. Why is it important? It's important because currently lung disease is the most common cause of scleroderma-related deaths. If you go back a few decades to the 1970s, it was scleroderma renal crisis, but we've gotten very good at both preventing and treating the scleroderma renal crisis, and the result is that mortality associated with kidney disease is way down. That's those ACE and those ARB medications you take for your nose. They also do a very good job of protecting the kidney. So currently, scleroderma, both the pulmonary hypertension and the interstitial lung disease are the most common causes of scleroderma-related mortality. So it's important. And does that mean everybody? I've given you a wide spectrum, anywhere from 25% of patients with symptomatic to as much as 85% of patients will be found to have lung disease by CAT scan or PFTs. So does that mean everybody's at risk of death? Well, no, it's really those patients who progress to more severe lung disease. So it's very important if you do have lung disease to sort of grade the severity and understand where things might stand in the spectrum of lung disease. So we have two different ways we grade the severity of lung involvement in scleroderma. One way is by the pulmonary function test. And again, I hope you've all had a chance to see, your own pulmonary function test or a family member's pulmonary function test. These are what a standardized report looks like. There's 3 different sections to this test. There's the first, which is the spirometry, and that's really an airflow and abnormal primarily in patients with asthma and emphysema. That's what we use to diagnose asthma and emphysema. Then the lung volumes, and this is sort of where the money is in diseases, all sorts of interstitial lung diseases, in the sense that scleroderma causes this fibrosis or scarring in the lung. The lungs get smaller. So your total lung capacity here is reduced, and also this number here is the resting lung capacity. So basically all of the lung volumes are going to be reduced if there's significant interstitial lung disease. This number here, the vital capacity test, is also a surrogate marker of the total lung capacity. It's both the flow and the volume. The reason these numbers are abnormal here is if you have low volumes, you have low flow, so they sort of just follow suit. Then the last portion of the pulmonary function test is the diffusion capacity, which is the gas exchange portion. So it's telling you how well those little air sacs and those little capillaries exchange gas between them. And while it's the most sensitive marker of lung disease, it's also non-specific. There are a lot of different things that cause abnormalities in diffusion capacity. Anemia, pulmonary vascular disease, smoking, breathing in a lot of pollution. So it's a very non-specific test. In addition, it's problematic because if you test the same person week to week, the numbers vary as much as 15%. So you might have a test where your numbers drop to 13 and a half to 11 and a half, and your doctor's not excited, but that's because of this. We generally don't get excited unless there's a pretty big change. Just as likely on the next test, it'll be right back up. So the diffusion capacity, while very sensitive, is also very variable and very nonspecific. So we gauge severity of disease by both the pulmonary function test and also by CAT scans. So the CAT scans, there are several different grading systems that have been developed to grade the CAT scan in interstitial lung disease. I'm just going to give you sort of a ballpark, and then we'll look at the simplest system. So here you can see there's minimal involvement, mostly this pattern of what we call ground glass. You see that sort of gray-white area down here. It's really involving just the lung bases, which are the most common areas of involvement, and just the bases right along the border of the lung. And then as disease progresses, you might see more of this ground glass spreading throughout other areas of the lung. And then you might see the development of some scar tissue here, which we refer to as honeycomb. And then in really severe, more end-stage disease, you begin to see these honeycomb changes throughout the lungs. So it not only changes in the amount of your lung that's involved, but also the way your lung looks involved, from ground glass to honeycomb fibrosis. So it will evolve as well as potentially spread. So here's how we use the severity to try to understand prognosis or outcome in lung function. In this study, this is from the University of Pittsburgh. It's one of their older studies that looked at the natural history. This study was done really prior to us having any treatment for interstitial lung disease, and so none of these patients were treated. So they looked at the absolute worst vital capacity the patients had over the course of their time at Pittsburgh. And they put them into one of 3 groups, and then they looked at their mortality over 10 years. So what they found is patients who maintained a vital capacity of greater than 75% had the same expected outcome in terms of survival as did the general population of scleroderma patients without lung disease. However, the patients who had a vital capacity that had fallen to less than 55% predicted had an accelerated death, so their cumulative survival was much less than those who had greater than 75%, and then the group in between 75 and 55% was, as you might expect, somewhere in between. So clearly, we'd love to keep everybody up here closer to 75%, and certainly not allow vital capacity, if possible, to drop down below 55%. Similarly, this is a study that looked radiographically. Now, we generally really hang our hats on the pulmonary function test, but not everybody can perform a good pulmonary function test. So sometimes we have to rely more on the radiology to give us some sense of how severe the lung disease is. This is the simplest study, the simplest way where patients were simply looked at as, do you have a lot of lung involvement or a little lung involvement? And the cutoff was 10%. So if you could look at the CAT scan and say there's less than 10% of the lung involved, then the survival was pretty good. If you looked and saw that there was more than 30% of the lung involved, survival was less. They labeled these limited and extensive. And then those patients who wasn't really clear whether there was more, they were sort of in this gray zone of, not clearly less than 10, but not clearly greater than 30, then they fell back to using that forced vital capacity test with a divisor of 70%. And that's the way we grade the CAT scan in terms of lung involvement, and also just to understand a little bit about the prognosis. But on the other hand, very positive things. If you look again, this is the Pittsburgh data. The lower line is survival between 1972 to 76. Over that, years of diagnosis is 10 years, so patients that were followed there during these serial time periods of about five years. And you can see we've really seen improvement, and this only goes up to 1992 to 1997. I think the next line will probably show you further improvement. So with treatment, we've actually made some headway in decreasing mortality associated with scleroderma. So I think that's the positive thing. So I put this up here really just so we can talk about pulmonary fibrosis and interstitial lung disease. Oftentimes, the first time I see a patient, they come into the office and they've heard they have pulmonary fibrosis, and they go online and they read about it, and they come in really panicked. Because if you look at pulmonary fibrosis on the internet, you're going to be guided to all these websites that talk about idiopathic pulmonary fibrosis, or IPF. And that's really scary because, until a year or so ago, there were no treatments for it. And even with those treatments, life expectancy is pretty poor. So it's pretty worrisome when you look at that data. So scleroderma-associated interstitial lung disease is not IPF. And it carries a much better prognosis than does IPF. And that can be said even if you have the fibrosis-looking CT scan as opposed to the round glass-looking CT scan. So here's this is a fairly large study where they looked at patients who had interstitial lung disease associated with collagen vascular disease, or patients who had idiopathic lung disease, and these were mostly idiopathic pulmonary fibrosis. And if you look at the months, this is in months all the way up to 192 months, if you looked at the percent survival, it's much higher in patients with collagen vascular associated interstitial lung disease. And if you look here, they broke them down with what sort of pattern you have on your CAT scan. That's what I was showing you earlier, so that brown glass versus those honeycombs. And it really didn't matter if you had the honeycombs, you still did much better than these patients with idiopathic pulmonary fibrosis. So it is not the same disease, and it does not carry the same poor prognosis that IPF does. Then, so now we change to, so who do we treat? And this is really one of the biggest challenges. The medications we have to treat these drugs all have a number of different side effects, and so we don't give them lightly. So we really would love to be able to identify ahead of time who is at most risk of developing or going on to severe lung disease, and that really is a challenge. We have a couple of different areas to sort of get some information. One is, again, some older data. This data was generated by looking at patients who had developed severe lung disease, but who had a series of pulmonary function tests going back over the 5 years before ending up with their severe lung disease. This was, again, in a period before treatment. This is that same data that I showed earlier from Pittsburgh. And they looked at, where do you lose lung volume? What's the highest period of risk? And so when they looked at the patients, sort of down here, and they looked, okay, so a year or two into their illness, and so these were like 0 to 2 years after their first non-Raynaud's symptoms. That's how the clock started. So most of the lung volumes were lost in those first 2 years. Then over year 3 and 4, there was still some lung volume loss. By year 4 and 5, it was really pretty minimal. So this led us to sort of conclude, well, this is the really important time to jump in and to begin treatment and try to prevent lung loss, because if we wait till here, we're going to be in trouble. The lung disease is probably sort of burned out right there. And what we have known, and we're going to look a little bit at the clinical trials, is quite often we're successful in holding the lung disease, maybe getting some improvement, but we don't get 25% improvement with treatment. So really, this is where we want to be. This is where we want to be involved when the lung disease is most declining most rapidly. However, so we hung our hat on that for years, and then we looked at the data from the Scleroderma lung study, which was the first big double-blinded, randomized controlled clinical trial run by the NIH, where we looked at Cytoxan versus no treatment, so a placebo arm for scleroderma interstitial lung disease. And we went back and looking at the placebo group, those who didn't receive medication, to look at who lost lung volume. Again, trying to predict who we should treat, who was going to get worse. And what this really told us is, this is over the 12-month period looking at what happened to the forced vital capacity. And this group here, the top group, had disease greater than 4 years. They also lost lung function. And they lost lung function basically at the same rate as those patients here who really only had disease 0 to 2 years. So it led us to question, well, gee, we didn't expect that. We expected those patients who were out more than 4 years not to have lost a lot of lung volume. So we weren't sure what that was about. And then we sort of looked at, well, who loses lung volume more? So if you started out with a lot of fibrosis, versus if you started out with just a little bit of fibrosis, here the two lines are divided by how much baseline lung fibrosis you have. And it turns out, even if you are having this disease greater than 4 years, if you had a lot of fibrosis at baseline, you were at risk for actually losing more lung function. So this sort of threw a monkey wrench into what we had all thought for years, with the exception that at baseline the groups were very, very different. Whereas the prior study looked at patients who already had severe lung disease and looked back. Patients here who enrolled who had disease more than 4 years had very little. They actually started out with a vital count of 78%. So we think these are different patient populations, not that there's anything fundamentally wrong with the data from each study, but it makes it all that much more challenging to try to figure out who's at risk and who should be treated and who shouldn't be treated. So we're still trying to sort through some of that stuff. So what are the treatment arms and what are the therapies? So there's data in 4 different areas I want to talk about. One is mycophenolate, also known as CellCept, versus Cytoxan. We're also going to then briefly touch on Rituxan, stem cell transplant, and lung transplant, sort of newer therapies. The mycophenolate versus Cytoxan I'll start with, and I'm really only going to show you sort of one slide from each of these. So this is the Scleroderma lung study 2. That was just published in Lancet. Was it early this year? Yeah, in July of this year. So this is the big second study where we looked at patients who were randomly assigned in a blinded fashion to receive either 12 months of Cytoxan or 24 months of mycophenolate. The Cytoxan was in the second 12 months, given placebo. The reason the Cytoxan was only used for 12 months is that's about the maximum amount of drug we will use in Cytoxan, because if you go with doses higher than that, meaning more prolonged treatment, this risk of secondary cancers becomes higher. So we generally limit treatment in Cytoxan to about a year. So this is really sort of sums it all up. While the study is said to have been sort of negative, because the goal of the study was to prove that mycophenolate was superior to Cytoxan in treating interstitial lung disease, it did not show that it was superior, but it did show it was equally effective. And more important, and the reason most of us feel like it really wasn't a negative trial, is it showed that mycophenolate is much, much better tolerated with many fewer side effects. So overall, I think it is the first line for treatment of interstitial lung disease associated with scleroderma. So let me just sum this up, because I know this sort of looks scary. So it's really quite simple. These are the patients in blue who got mycophenolate. These are the patients in orange who got Cytoxan. This is the skin scores. We're not going to look at that. So the patients on the top half were responders. So 71.7. So 72% of patients had a response to mycophenolate. About 65 had a response to Cytoxan. That statistically wasn't different. And there were 30%, about a third in each group, which had no response. And so while net, you looked at the overall, there was only a 4.1% improvement in the vital capacity. That's sort of what happens when you average people who have negative value and people who have positive value. There were patients in both groups who had 10 to 15% or better response to these medications. So clearly there are patients who are really going to benefit by mycophenolate. You don't see that when you look at the non-responders. So again, we need a way to identify who these responders will be. Right now, the best mechanism we have is to start the drug and watch the pulmonary function test and see if you fit into that responder group. So I think this was actually a very good study. It showed, a fair number of patients will respond. A smaller number of patients will have a pretty robust response and really very well tolerated. But if you fall into this non-responder group, where do we go then? So I think the next treatment we start to think about is a drug called rituximab. This is an IV infusion therapy. It's pretty costly and it's hard to get approved through most insurances. It has been studied as a salvage therapy for patients with scleroderma who have failed what is considered standard of care. This was a European study. Their standard of care had been IV cytoxin. So most of those patients had failed IV cytoxin. Some had failed IV cytoxin and mycophenolate. And so then went on. And the initial trial, which showed the data at a year, was comparator of doing nothing versus Rituxan, and Rituxan seemed to have an effect. This then followed 8 of those patients out for an additional year. So this is 2 years data. As you can see, most people had some response. There's really only one person who continued to decline despite Rituxan. Some people didn't lose any more lung function, but didn't get worse. And then there were a number of patients who improved. So I think we don't quite know enough about Rituxan at this point, but for people who are having persistent lung function decline despite cytoxan or mycophenolate, this seems to be a drug that offers us at least stabilization and perhaps some improvement. And so that is usually where we go as second line when we have failed the first line treatment, although again, we usually struggle to get this medication approved. It is definitely a drug that needs more data in terms of its role in scleroderma. Next, I don't look at most of the slides, really just for the top here. The role of stem cell transplant in scleroderma. There were 2 major trials that were done in a randomized fashion. Obviously, you couldn't blind these folks, but they either got a year of cytoxan intravenously for 12 months, or they underwent stem cell transplant. 2 large studies in the US is the Scott trial, which has not been published yet, just finishing the follow-up phase. But the Astis trial was published about a year and a half ago, and this is the European trial of 156 patients. So stem cell transplant in that group, so they enrolled their patients between 2001 and 2009, very similar protocol and endpoint as the Scott trial. The major difference was the use of total body irradiation, which has been used in the Scott trial. It's fairly standard in the US, with the exception of a handful of centers, including our center, which does not do total body irradiation, with the feeling that it's more injurious to the lungs, even when the lung is protected. So the Europeans didn't use any total body irradiation. And so here are the patient population. They're ages 16 to 65. They had disease duration. It had to be less than 4 years. And if your skin score was 15, 15 or more, you had to have another organ system involved. So that could be heart, lungs, or kidney involvement. That was the major group. And then there were patients they involved who had they involved in rapidly progressive skin disease and high inflammatory markers in their blood. So these were patients who had skin diseases of 20 early on in their disease and were highly inflamed. So those were the 2 groups that were enrolled. They did exclude patients who had significant concomitant, mostly pulmonary vascular disease. So pulmonary hypertension is known to be a risk factor for stem cell transplant. So they excluded patients who had significant pulmonary hypertension. And they also excluded patients who had a prolonged course of cytoxan beforehand, because, as I said, you can't really go with cytoxan much more than a year. So they couldn't be in the control arm. And so this is what we found with stem cell transplant. So in stem cell transplant, the important thing to recognize is where the 2 lines cross. So there is a treatment-associated mortality in stem cell transplant. And so at the beginning, like if you look, and this HRS stands for hazards ratio, and what that means is that if you had undergone stem cell transplant versus this treatment with cytoxan, at 3 months, you were 2.4 times as likely to suffer mortality than if you had stem cell transplant. At 6 months, you're about 1.5 times more likely. Mind you, neither of those, although this seems large, neither of those were clinically significant or statistically significant. However, 1 year, mortality was definitely favored by having undergone stem cell transplant, and that goes out all the way out to the 10-year follow-up. The 10-year follow-up hazard ratio is well under 1 for having a better outcome with stem cell transplant. So the bottom line is that a highly select group of patients is effective in providing more long-term survival. The problem is the upfront mortality. The transplant-related mortality was 10.1 in this study. So it's really identifying those patients who are at high risk of early mortality associated with scleroderma. And those are probably the group that should undergo stem cell transplant. But that number is pretty big, and that can be very scary. So, it's a tough decision to make in terms of whether or not to recommend this in somebody who you think overall has a good short-term mortality. The deaths so here we just look at the cause of death in the transplant group versus the control group. So most of the control groups, the deaths were related to progressive disease or to the secondary malignancies probably associated with more long-term use of cytoxan. In the stem cell group, about half of them were transplant-related. As I said, that was, age was 10% of that group, and then disease progression was the other big group. And then the disease progression, so major organ failures, of course, developed more commonly in the control group than in the transplant group. So it is an effective treatment. The big problem with stem cell transplant is that upfront mortality associated with the transplant itself. If you get past that, your outcomes are going to be better from the standpoint of organ system failures and also from the standpoint of long-term mortality. So lung transplant, I have to touch on lung transplant since, honestly, 2006, the ISHLT, which is the Heart and Lung Transplant International Group, endorsed lung transplant for connective tissue associated interstitial lung disease, and it's really taken transplant centers a long time, about a decade, to get on board that we should be doing lung transplant for patients with scleroderma, that the risks are not unexceptionally high. And actually, since I made this slide, there have been a few more studies that have come out, but I like these two because this is a systematic study of all of the literature looking at patients with scleroderma who undergo transplant, and this is a large, well-controlled trial out of San Francisco. So I just want to show you quickly some of these results. So in the first, they looked at all the studies that were potentially relevant. They wanted studies that looked at scleroderma, lung transplant, and reported mortality at some point. And honestly, there were only 7 articles that met those criteria. And this is really just to show you the centers. So if you look down here, these were the centers. And these are the centers that we know do most lung transplants. So there's UCLA, there's Pittsburgh, there's Hopkins, there's UCSF, and then there's Toronto, Israel. And this is the UNOS, which is the data. It's the U.S. transplant sort of registry. And if you look, most of these, I'm just going to show pretty similar outcomes for scleroderma and non-scleroderma. These guys show the best outcomes. When you look at their study, they excluded a lot of patients who had GI disease. And so throughout most of these, the transplant outcomes were very similar between the two groups. Here, the only thing that I'm going to point out, when you're looking at scleroderma patients, you probably need to be comparing ILD to ILD. The problem is when you compare ILD with people who have COPD or cystic fibrosis, we know their outcomes are better. If you compare idiopathic pulmonary fibrosis with scleroderma is just as well. And that was the point of this was a study at UCSF where they looked at their IPF and they looked at their scleroderma and they matched them 2-to-1 for gender, for age, for a number of different variables, and then they compared how they did in a transplant, and it turned out that these folks did just as well in terms of their overall survival, their these looked at patients specifically who had significant esophageal disease. It did not predict worsening outcomes. And then when they looked at rejection, and rejection is the major way by which the lungs dysfunction, the outcomes are the same. So therefore, the data suggests we really should be more aggressive in referring patients. The big problem we have is when to refer an individual. Lung transplant still only has a 5-year mortality. The 5-year outcomes are still about 50% 5-year survival. And unlike things like idiopathic pulmonary fibrosis, which is an unremitting loss of lung function, in scleroderma we usually get a handle on lung function and it stabilizes. So the big question is, when do you refer? Because this person's long-term survival might be much better without transplant. So a lot of it is trying to understand the trajectory. It's symptoms, not just mortality. It's quality of life issue. The additional development of pulmonary arterial hypertension, usually a combination of the two really gives a poor outcome, and so these patients are usually better with transplant. So there's, we really need more data to tell us when it is appropriate to begin to think about transplant referrals for our patients. Our center here is really committed to doing scleroderma transplants. Not all centers across the U.S. are doing scleroderma still. There's only a handful of patients that welcome scleroderma transplantations. And the last thing I want to run just a couple of slides to sort of talk about the aspiration lung injury, which is another really important thing for folks with scleroderma. So these pictures are really just to sort of explain why stomach contents gets into the lungs and why people aspirate. It all has to do with where the esophagus sits relative to the trachea. This is the esophagus here. So this is, you swallow down here, food comes down, which should be a tiny little esophagus, and then in front of that is the trachea, and the two at the top are open with the exception of this little piece, this little flap called the epiglottis, which closes over the windpipe when you swallow to protect it from things going down the wrong way. So in a normal situation here, what you swallow stays in the stomach because there's this little lower esophageal sphincter, we call it, that in a normal esophagus closes and doesn't allow food to reflux back out. But in the situation here where food refluxes back up, it's not very hard to flip over and go down the wrong way, as they're sort of illustrated here, and fill up your portable air sacs with gastric contents. So why does that happen in scleroderma? This is why it happens. It happens because the esophagus is not normal. As you saw, that little sphincter is really, requires the esophagus to be a little narrow so that the sphincter closes over it to protect, prevent things from coming back up out of the stomach. This is the normal esophagus. It's sort of a thick wall with a tiny little hole in the center. And these are scleroderma esophaguses. This one's huge. There's an air fluid level. So when this person lied flat for the CAT scan, all the liquid from their stomach came back up and created this little fluid level here. And this is debris. This is soft tissue debris. So this is food in the esophagus when this person lied flat. There are multiple studies that have shown us, both in scleroderma and in idiopathic pulmonary fibrosis, that aspiration of stomach contents will contribute to progressive loss of lung function. So we know this can be a driving factor in some people, and we think that perhaps people who are deteriorating late in the course of disease is being driven more by aspiration because the esophageal dysfunction occurs progressively as disease goes on. So it's very important in terms of lung function to sort of prevent this from happening. So what options do we have for prevention? This is not something that can easily be fixed. Once you lose that esophageal dysfunction, there's no way to get that muscle tone back. So one is we use gravity. Gravity is your friend when you lie flat. When you lie flat here, the food is just going to come right back up if there's no sphincter, no competent sphincter here to prevent it. So it's just coming right back up. So you really want to use gravity to help keep things in the stomach. So the three ways, there are many ways you can do it, but three easier ways. One is the wedge pillows. I mean, a lot of people don't like the wedge pillows, but they do work. They're very effective. You can put the wedge pillow between the box spring and the mattress to lift the whole mattress, and that might be a little more comfortable. Or some people just put blocks under the head of their bed. There are other more creative ways as well, but the important thing is to try to have your head 6 or 8 inches higher than your lower back, and you don't want to just elevate at the neck, because that's just going to kink the esophagus. You really need to elevate from the mid or lower back up. So elevation is really important. And then the last thing I wanted to touch upon were proton pump inhibitors, especially because there's been so much bad press about proton pump inhibitors this past year and the development of the potential development of renal insufficiency or renal disease associated with them. So what are the pros of proton pump inhibitors? So what they do is they neutralize the stomach acid. This is important from a number of different standpoints. One, it protects the lower esophagus. So when you have the acid flowing out of your stomach into your lower esophagus, it burns the lower esophagus. It causes changes called Barrett's esophagus, which is a risk factor for the eventual development of esophageal cancer. So we take that very seriously. So neutralizing the acid protects the lower esophagus from those changes. It alleviates the symptoms of GERD. What it doesn't do is it doesn't really prevent reflux from happening. So you still have the reflux, but now it's non-acidic. And so it doesn't prevent you from aspirating, but the aspiration of non-acidic contents into the lungs is much less injurious to the lungs than is the aspiration of acid. So it's very important in protecting the lungs from the acid injury of acidic stuff in your stomach. So it's important for these two reasons, both the Barrett's esophagus and lung injury, to neutralize the acid in your stomach. However, a number of different things have been associated, most recently the association with renal dysfunction. So the development of chronic renal disease has got a hazard ratio, as I showed you earlier, is 1.44. So a slight increase in renal dysfunction seen in patients with chronic use of proton pump inhibitors. So that's worrisome, but it is something we're always monitoring for in patients with scleroderma who monitor a number of different things, including renal function. Loss of bone density. So this is actually a point of contention. There are studies that have shown people who have been on them regularly for 10 years have no difference in bone density, so I don't think we have the answer on whether this is true. It can impair the absorption of other medications and some nutrients. So again, we usually caution not using it when you're taking some of your other medications. And lastly, it can contribute to the growth of gut and bowel bacteria just because the acidity in the stomach will usually kill them. So if you neutralize acidity, these bacteria tend to survive. So that's definitely true. The idea that it impairs cognition, again, is something that has not been borne out in multiple trials, but I think that's not yet known. But almost all of the data would suggest, and the feeling amongst us, we people who do scleroderma, is that the pros far outweigh the cons in terms of treatment of the reflux disease in scleroderma. And proton pump inhibitors have been shown to be superior to H2 blockers, which are the things like Zantac. Now, that being said, you have a completely normal pulmonary function test, and your esophagus does not look that bad on the CT scan, then it's fine. We should routinely be putting absolutely everybody on those drugs, but there are patients who clearly have more benefit. So I think those are the things that should be considered. Do you have that lung disease? And is your esophagus really large? We have a study coming out looking at what we call the widest esophageal diameter and its relationship to lung function decline. And it shows that the esophagus is, the more your lung function will decline. So I think that we have to have a sensible approach to these because there are downsides. And there's not one good answer, one good fit for everybody. So I think that concludes our programs. So. All right, I left us a little time for questions. I think we got a little late start, so go ahead.
I have two questions. One is, I'd like